and you wanna settle that scar, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winds are leaving. It's redemption season. Long live the young and high. Cheers to a brand new start. We're revived and breathing to live a life of freedom. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, and life is a race we run, so run till the race is won. Don't you ever give up, no, no, never give up. Life is a race we run, so run till the race is won. Don't you ever give up, we will never give up. To everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on.
Hi, everyone. Welcome to this exciting new webinar. It's a pleasure to introduce Dr. Mostacci. She's a neurologist at the Istituto delle Scienze Neurologiche di Bologna. I hope I have pronounced it right. In Italy, she's mainly engaged with research and clinical activity in epileptology, with main fields of interest in women and epilepsy, vagus nerve stimulation, and non-epileptic psychogenic seizure. She's currently the chair of the Epilepsy and Gender Commission of the Italian chapter of the ILAE. And our counterpart is Dr. Meador. He's a professor of neurology and neuroscience at Stanford University, clinical director of the Stanford Comprehensive Epilepsy Center. He graduated from Georgia Institute of Technology. He received his MD from the Medical College of Georgia and completed his internship at University of Virginia. He has been faculty of the Medical College of Georgia and becoming the Charbonnier Professor of Neurology, Chair of Neurology at Georgetown University, the Melvin Greer Professor of Neurology and Neuroscience at University of Florida, and Professor of Neurology and Pediatrics at Emory University. He has over 400 peer-reviewed publications related to epilepsy and neuropsychological mechanisms, and he has served as the PI for a long-running NIH multi-center study of pregnancy outcomes in women with epilepsy and their children. So our learning objectives are from the ILAE curriculum. 2.6 3.2, which is provide guidance regarding pregnancy, including teratogenicity of the various anti-epileptic drugs, and the 3.4, which is to demonstrate knowledge about the risk and opportunities associated with drug discontinuation and methodologies for individualized implementation. So welcome everyone, Dr. Mostacci. It's a pleasure to have you on board, and Dr. Meador also, it's a pleasure to have you on board. Thank you very much.
Okay, may I start? Thank you, Sebastian, and thank the organizer for inviting me to this exciting talk in such a good company. Hello, everybody. My task today will be to underline the reason to choose to continue Valproate in spite of its known disadvantages in women and in girls and in women of childbearing potential. These are my disclosures. Professor Meador will go in depth into the evidences on anti-seizure medication and especially Valproate in pregnancy and their risk to the offspring. Therefore, I will only mention the major facts that constitute the reason why we are here today. Generally speaking, anti-seizure medication exposure in the womb is associated with an adjunctive risk of malformations. And during the last 20 years, several new anti-seizure medications hit the market, and several information on the risk associated to the single substances were collected, mainly thanks to the 3 larger registries of anti-seizure medication in pregnancy, which collected thousands of pregnancies and exposed to anti-seizure medications in monotherapy. This data clearly show that anti-seizure medications are not equal in terms of risk to the fetus, and in these figures from a very useful review by the main researchers of the Europe registry, you can see from left to right the most used anti-seizure medications in order of teratogenicity, and Valproate is unquestionably at the bottom of the league. What's more, several studies investigated the relationship between intrauterine exposure to Valproate and measures of intelligence and of neurodevelopment, converging on a poorer cognitive development at different ages, compared to unexposed children born to mother with and without epilepsy, and to children exposed to other anti-seizure medications. Furthermore, significantly increased the rates of behavioral problems, and notably including autism, were reported after intrauterine exposure to Valproate. For all these reasons, the regulatory medicine authorities of different countries issued some recommendation. I work in Europe where recommendations are particularly strict. The first one was released in 2014 and it was further strengthened in 2018. And it states that concerning epilepsy, Valproate should be used in girls and women of childbearing potential only when other treatments are ineffective or not tolerated, and only if a concomitant effective contraceptive method, meaning intrauterine device or hormonal contraception, is used. But is doing without Valproate painless? It's not always so, and as we will see, in fact, there are situations in which its replacement is not easy, and its continuation could be the safer solution, even in girls and women of childbearing potential. In the next minutes, I will deal with some specific situations, and namely, I will deal with some epileptic medical conditions and which poses particular problems, and the situation of unplanned pregnancy while on Valproate. And I will also deal with the clinical and legal counts of shifting to another medication, another anti-seizure medication, and with the ethical consideration other than teratogenicity. The first aspect to consider when deciding what to do with a woman who's taking Valproate for epilepsy is what epilepsy she has. Probably the most sensitive case is the one of idiopathic or genetic generalized epilepsies, which are conditions particularly responsive to Valproate, and where on the other hand, suitable options, alternative options are scanty, are limited. As a first consideration, we must acknowledge that with the exception of absence syndromes, the literature lacks high quality studies, and thus the literature lacks strong recommendation for any anti-seizure medication in idiopathic generalized epilepsies. That said, Valproate is the only medication that has consistently proved effective in all three seizure types that characterize the idiopathic generalized epilepsy, which are absence seizures, myoclonic seizures, and generalized tonic-clonic seizures. In most studies in which it was compared to other anti-seizure medication, it proved to be the most effective. And as a final consideration, different from others, no paradoxical effect was reported for any kind of seizures. Moreover, let's take a look again at the evidences we have from the pregnancy registries. Not only the type of anti-seizure medication, even the doses count. These are data from the Europe registries. In the Europe registry, there is no control population not taking medication, and the comparator is lamotrigine at low doses, meaning below or equal to 302.5 milligrams per day. And as we can see, Valproate in here, Valproate low doses, which means equal or below 650, still carries a higher risk than lamotrigine low doses, which is this line, but is considerably less harmful than Valproate high doses or average doses. And indeed, it's something like high doses carbamazepine. And a dose dependency was also found in most studies exploring the consequences on the cognitive development of the offspring. In fact, there are no consistent data of a major cognitive effect of doses for doses lower than 800 milligrams per day, though a higher risk of below average performances in specific abilities have been reported also for low doses Valproate. Unfortunately, we must say that we do not have the same partly reassuring data on dose dependency concerning the risk for autism. But why are this information useful in the clinical practice? Because several studies explored the usefulness of low doses in juvenile myoclonic epilepsy. As we were saying before the webinar with Sebastian, juvenile myoclonic epilepsy is probably our worst nightmare when we have to avoid Valproate, because this syndrome is in this syndrome, not only are ineffective, not only other anti-seizure medication are not only ineffective, but may have a paradoxical effect. For example, carbamazepine, oxcarbazepine, phenytoin, but also lamotrigine to a lesser extent, and possibly also lacosamide. And juvenile myoclonic epilepsy is a syndrome in which we generally have to protract the therapy long-term, many times for a lifetime. And these studies that use the Valproate doses lower than 1,000 or 800, it depends on the study. And this Greek study, for example, used a dose of 500 milligrams once per day. And they found out that these low doses are usually effective as higher doses. So we have the chance to continue Valproate at doses which are incontestably less harmful than higher doses. That's very important. We also have some data on the consequences of avoiding Valproate in women of childbearing potential with the idiopathic generalized epilepsies. This is a retrospective study which was conducted in 2 Italian centers, and it showed a significantly higher proportion of seizure freedom in women with idiopathic generalized epilepsies compared to women taking Valproate compared to those who didn't take Valproate. These are the data, which are, I think, impressive, and especially for juvenile myoclonic epilepsy again. This same group reported also the rate of seizure remission in their population with the idiopathic generalized epilepsy, this time comparing males and females, and they found out that seizure remission was significantly lower in females, and it was mostly related to valproate treatment. Okay, let's look at the first part of the figure, because I thought that I put the animation, but I did not. Childhood absence epilepsy is a peculiar situation among the idiopathic generalized epilepsy. This is a class 1 study. As I told you, this is a rarity in idiopathic generalized epilepsies, demonstrating the superiority of ethosuximide and valproate on lamotrigine in childhood absence epilepsy. In this syndrome, therapy can usually be withdrawn very soon in life, before childbearing age, however. However, prescribing patterns change even in CAE, as we can see from this survey that we performed among Italian epileptologists. And we can see that Italian epileptologists choose ethosuximide or valproic acid as a first choice in CAE, but in an inverse proportion depending on the sex of the patient. So in female children, they choose mostly preferentially ethosuximide, and vice versa for male patients. However, if valproate was already started, as may be in situations in which generalized tonic-clonic seizures are present, occurred, as tonic-clonic generalized seizures are not responsive to ethosuximide, I think that valproate should be continued, or could be continued, until the age in which epilepsy is considered resolved and probably resolved, and therefore therapy is withdrawn. Shifting to lamotrigine seems pointless in such cases, and I'm pointing it out because the EMA, the European Medical Agency recommendation, applies to girls since the menarche. There were this that I presented were the evidences that make the discontinuation of valproate more difficult in idiopathic generalized epilepsies than in other situations. However, the decision should be individualized, as in all other situations that we clinicians face every day. With a group of European epileptologists, we made some recommendation, and concerning idiopathic generalized epilepsies, we suggested that specific aspects to consider should be age, as the likelihood of seizures tend to decrease with age. Type of seizure, as if some myoclonic seizure may be acceptable by the woman and of course by the physician. Generalized tonic-clonic seizure are not acceptable at all, and therefore, for the same reason, also previous unsuccessful withdrawal attempts leading to generalized tonic-clonic seizure recurrence are probably a red flag to discontinue. As in any other situation, however, the well-informed woman's will is crucial to the start. Now, moving from the idiopathic generalized epilepsy issue, we suggested that even women waiting for surgery who would probably withdraw medication in a second time, but very soon, and women with a terminal condition should not necessarily discontinue valproate. However, they should be recommended contraception. Other situation in which the epilepsy condition plays an important role in deciding to continue valproate should be all those in which, even if in childbearing age, the childbearing potential is reduced due to the severity of the disease. In this situation, we have two important reasons to continue valproate. The first is that in this situation, generally, we have a high chance of dangerous seizures, generalized tonic-clonic seizures, seizures with falls, that tend to respond, at least partly, to polytherapies, including valproate, like the very effective, almost magical combination with lamotrigine, or in Dravet syndrome, the combination stiripentol, valproate, and clobazam. And of course, the second reason is that in these conditions, pregnancy is unlikely. However, I must say that under this condition, preventing pregnancy in sexually active women is often a priority for the patients and for families, irrespective of the use of valproate, and due to the difficulties that these women could have in parenting a child, and due to the risk, the possible risk of recurrence of severe genetic diseases. Another important issue is what to do when the pregnancy has already started and the woman is taking valproate. Is it worth reducing or withdrawing valproate? If so, is there any period in the pregnancy after which it is only an hazard? $1,000,000 questions to which I think, to my knowledge, there are no clear answers yet. We know for sure that concerning structural teratogenesis, the first trimester is the most hazardous period, but we don't know about the interference with the cognitive development, which could theoretically occur at any time. And in most studies, women were exposed to antiepileptic drugs throughout pregnancy, precluding conclusions on whether the risk is related to a particular time period. The general rule, according to most authors, is to continue valproate if the woman is already pregnant. An important exception could be if we it could sound obvious, the situation in which we do not think that that woman needs the therapy. And maybe the best example again is a woman who had a child with absence epilepsy and in whom therapy had not been withdrawn yet. The dose could be on other occasion could be lowered if the previous history suggests it is safe enough to do so. That is merely to say that if the chance of tonic-clonic seizures is low. Even though we do not know exactly the risky period, the period of pregnancy should, however, in my opinion, play a role in the decision. The later we are in pregnancy, the less likely it is that withdrawing, shifting to another drug, or reducing the dose is useful. Even considering that to be safe, that process should be a time-requiring process. Usually, discontinuing valproate means shifting to another medication. However, when we start this process, we must consider the chance to lose seizure control, but also the chance of adverse events and the loss of adjunctive benefits from valproate. It is, I think, a common experience that women shifting from valproate to another medication experience a worsening of their migraine, of course, if they are migraineurs, and sometimes so intense to require an additional prophylactic treatment. However, I think this should be considered a minor problem, of course, whereas we must be particularly careful to the loss of the beneficial effect on mood, which could be particularly relevant if we have shifted to a medication like levetiracetam or topiramate, which could worsen or even provoke a mood disorder. Least but not last, finally, it cannot be ignored that we have little or no information on fatal adverse events of several new anti-seizure medications. Notably, we know barely nothing on perampanel or racosamide, the ones that were, at least in Europe, the ones that were more recently licensed as an adjunctive therapy in some idiopathic generalized epilepsies, in tonic-clonic seizures, generalized tonic-clonic seizures. And we still have a little information, even though a growing body of information on many anti-seizure medications concerning possible cognitive and behavioral consequences on the offspring. Since the decision to avoid valproate is based on clear literature data concerning its teratogenicity, ideal alternative drugs should be incontestably less harmful in the event of pregnancy. And to make it possible, a clinician should participate to pregnancy. Clinicians and patients should participate in pregnancy registries, and maybe in pregnancy registries should involve also information on later consequences on the offspring, I think. As a possible and expected additional problem, the legal prescription requirements, which of course are different for each country, may further complicate the shift. As Epilepsy and Gender Commission of the Italian chapter, we performed a revision on efficacy, teratogenicity, and legal requirements for anti-seizure medications in idiopathic generalized epilepsy. And we showed that, for example, in Italy, prescribing levetiracetam as monotherapy to a patient with juvenile myoclonic epilepsy represents an off-label prescription requiring supplemental pharmacovigilance procedures, and more than that, reimbursement is not even contemplated for levetiracetam in monotherapy for idiopathic generalized epilepsy with the generalized tonic-clonic seizures alone. Prescription rules may vary throughout Europe, but are generally very consistent across Europe. And a further major problem is that we found some inconsistency between the summary of product characteristics, and in some cases they could even differ between different brands of the same active principle about pregnancy, about contraindication or special recommendation for pregnancy. Starting from all these considerations, we have done today together, and going beyond, several important ethical issues were raised. I suggest to read these papers, and some of them are: is it right to impose a contraception? Is it illicit to deny a woman to decide over her own therapy? Is it illicit to deny a woman an effective therapy, which would be the first choice for men in the same condition? And another problem is that when the regulatory authorities refer to childbearing potential, they refer to a biological condition, namely being a fertile woman, being capable of conceiving, not dealing with the chance of women who do not have sexual intercourses with men because they are sexually inactive or homosexual. There should be no reason to deny a valproate or to impose an invasive contraception to these women. But the recommendation, the EMA recommendation, says literally that they apply to female patients from the time they become able to have children. So I am about to conclude, and I want to do it with the most important message, which is, according to me, that every person has the right to be fully informed and to express a preference for her or his treatment. And the final therapeutic choice in this case should be made together by the clinician, even in this case, by the clinician and the well-informed woman after designing, if possible, as far as possible, a well-defined risk-to-benefit ratio. And as clinicians, we should try to avoid and discontinue valproate in girls and women of childbearing potential whenever it is possible. But this doesn't mean that we should do it whatever it takes. I want to thank the Epilepsy Center led by Professor Tinuper, where I work in Bologna, and the Epilepsy Gender Commission of the Italian chapter of the ILAE. And I want to thank you with this picture of my hometown, Bologna. This is Palazzo del Podestà, lit up in purple for the last International Epilepsy Day. Thank you.
Dr. and Professor Kimford Meador. And now we are going to discuss the reasons why probably it's advisable to do a discontinuation of valproic acid in women of reproductive age. Dr. Meador, please.
Thank you. It's a pleasure to be here today. I'm going to present the counterpoint. I think if you sat and talked with Barbara and I, we'd have very similar opinions about the management of women and the use of this drug in pregnancy. But we're trying to present today the pros and cons so that you're better informed. First, my financial disclosures. Most of my income comes from patient care and grant research. I do some consultant work, but that money goes to a nonprofit that pays a portion to my university, and I do not receive the money directly. My short answer is to discontinue the drug. The longer answer is discontinue for a large majority of women with childbearing potential. Make sure the minority who might choose to continue fully understand the risks and benefits. It is not acceptable not to give informed consent. A woman cannot make an informed consent decision on her health care if she doesn't understand the risks and benefits, and to some degree, the complexity of that information. Not just a yes, no, it's good, it's bad. Here's our dilemma. Drugs are generally contraindicated in pregnancy. Most women with epilepsy, however, are unable to stop their anti-seizure medications due to the risk of seizures. As a group, both somatic and functional neurodevelopment are reduced in offspring of women with epilepsy. However, the majority of women are normal, but there is increased risks do exist. This is a slide from Tolbert Thompson showing the risk across different drugs for malformations, major malformations across some of the most commonly used drugs that we have. You can see this differential risk across the drugs. We can group these drugs here as being the ones most safe. They're barely above, they're a little bit above the general population risk for major malformations. And then we have valproate at the highest risk with phenobarbital and an intermediate risk. Another way to look at this is as a function of dose. And certainly there are teratogen works in a dose-dependent way. And we see this dose-dependent effect for all the anticonvulsant drugs with very large samples, even for lamotrigine. And if we get to the very low dose of valproate, less than 650 a day, it gets near the high dose. It overlaps with the high dose risks for lamotrigine, but not the low risk dose. Specific defects can occur, some of which are very serious, like spina bifida. This is limited to valproate and to a much lesser extent carbamazepine. And these risks have substantial consequence, taking the pathos of the mother's disease to a whole new level in her offspring. So it's something that the mothers have to know about and know about the relative risk. If we look at this study here from the URAP, we see that there's been a reduction in use of certain drugs, an increase in use of certain drugs from 2000 to 2013. Most dramatic decreases were seen for carbamazepine and for valproate, and decreases with phenobarbital. Increases have been for lamotrigine and for levetiracetam. What is the impact of these changes in dosages or change in drug use across this more than a decade? Well, there was a reduction in malformations, a 27% decrease in the prevalence of malformations from the beginning to the end of that time period, which is rather dramatic. Unfortunately, we don't have enough data about malformations. The pregnancy registries have been very useful in expanding our knowledge, but you can see here I have drugs that are colored and known to have relatively lower risks and those with relatively higher risk. And there's a bunch of medications there that are in white for which we have inadequate data at this point. And there continues to be a real conundrum once you burn through those first drugs that you know are safe as to what you do next. So in conclusion about anatomical teratogenicity, valproate poses a special risk with overall risk of major malformations greater than 9%. There's possible dose-dependent risk for all anti-seizure medications. And the risk for most anti-seizure medications, specific polytherapy combinations, are uncertain. I encourage you in your individual countries to have women join the ongoing pregnancy registries, because this is how we're going to get more and more information on these drugs for which we are uncertain at this point. What about behavioral teratogenicity? This was observed in the 1980s in animal studies where you could give dosages less than those that produce major malformation, but they produce lifelong cognitive or behavioral problems in the animals. So in the 1990s, we began a study, and this is the first cohort that we followed. And what we found was that children exposed to Valproate had on average 7 to 10 IQ point drop compared to children exposed to other major anticonvulsants at that time in the early 2000s. This effect was dose dependent across a variety of cognitive domains, as you would expect from a behavioral teratogen. And the question as to what is a safe dose is actually probably best addressed in this study by Gus Baker from the UK, where he had, this is a score in testing for controls in blue. You see a normal U-shaped curve. And then at the bottom, you see Valproate in high dosage being greater than 800 milligrams per day. You see a skew to the left with lower IQ scores in those children. In intermediate, in between, you see the Valproate dose, Valproate group at low dose, less than 800 milligrams a day, and they are not, their distribution is not like that of the controls. And in fact, they had statistically increased risk for language problems and for need for special education. So I'm not sure there is a defined safe low dose across women. Valproate also can cause autism spectrum disorder. This has been addressed with several studies, including population-based studies, and the risk for autism spectrum disorder is over 4%. Another thing that women need to know. What about other anticonvulsants other than those in our first study? There is some data for levetiracetam and topiramate, although the samples were low, especially for topiramate in this UK study. And we can see that Valproate, again, in this different cohort, has an increased risk of lower IQ. That was not seen for topiramate and for levetiracetam. This is preliminary data that we presented at the AES on our new cohort, which is largely made up of lamotrigine, levetiracetam, and it has the polytherapies, almost half were a combination of lamotrigine and levetiracetam. Most of the others had one of those two drugs in their combination for polytherapy. And we saw no differences in language and other cognitive outcomes between the children of women with epilepsy taking anti-seizure medications and a cohort of healthy children from healthy women. And we didn't see dose-dependent effects for our primary language outcome, but we did see on some of the secondary measures that there was some dose-dependent effect. Blood level, actually, we had blood levels in these women. And so this needs to be further delineated in future studies. So what anti-seizure medication do we have reasonable data on for cognitive outcomes? Well, here you can see those in yellow and those in orange as the groups with known lower and higher risk. And again, we have a problem with a large number of different types of anti-seizure medications for which we have inadequate data at this point. What about the Sinai? We talked about the efficacy of these drugs. So there's two studies, the Sinai 1 and 2. The one was published in 2007. And in that one, they divided up focal and generalized. This is the generalized epilepsy group, the group of epilepsies where Valproate has the greatest efficacy compared to other drugs. In fact, I don't see a reason to use Valproate in focal epilepsy. It has no particular special efficacy for seizure control in focal epilepsy compared to a variety of drugs. In this study, they compared Valproate to lamotrigine and topiramate. This is an open label randomized study. And they reported that efficacy for Valproate was higher, which it is. However, I want you to note the time at the graph at the bottom is the Kaplan-Meier graph to time for 12-month remission. And let's pay attention particularly to the column labeled year 1, where you're most likely, you have your largest samples, you're most likely also to see if there's differences in getting a new drug. And you can see it's about 4 to 11% fewer of the women taking lamotrigine or topiramate did not achieve seizure freedom. So it's not like Valproate works in all these women and lamotrigine and topiramate don't. The percentage of women being controlled with Valproate is higher, but there's a large group of people with generalized epilepsy that can be controlled with other agents. And more recently, the Sinai 2, comparing for generalized epilepsy, comparing Valproate to levetiracetam. Again, you can see on the left the 12-month time to remission, and on the right, the time to failure. And if we look out several years in terms of percentage of survival, people staying on the drug because it's controlling them and they're not having seizures, we can see it's about a less than a 20% chance. So about 80% would be controlled by Valproate that are going to get controlled by Valproate. I mean, they would be controlled by levetiracetam that would not, that about 80% would probably get controlled by levetiracetam of the ones that would be controlled compared to Valproate. So it's not a completely full or empty glass, it's something in between. So what are the clinical implications? Well, most children born to women with epilepsy are normal. Women with epilepsy of childbearing potential should be taking folate, which has been shown in several studies to enhance the cognitive outcomes and reduce the risk for autism-like behaviors in children of women with epilepsy on anticonvulsant drugs. All women of childbearing potential should receive informed consent, outlining the risk prior to conception. You can't wait to make these decisions till the woman's pregnant. It's a very difficult shift in these drugs during the pregnancy, and by the time you find out they're pregnant, generally there's been enough exposure to lead to anatomical pterogenetic risks. I think Valproate is a poor choice for most women of childbearing potential, but it may be useful for certain women, like the ones who were pointed out that have do not have intercourse, like nuns or homosexual women, or women that would be unlikely to have sex due to epileptic encephalopathies and severe impairments. It also might be a choice for a woman that really values the seizure control over the risk for pregnancy, but hopefully that woman would not be becoming pregnant. And if it is used in a woman with potential childbearing potential, its dose should be kept as low as possible. Again, although they're reasonably good alternatives to Valproate, once you have finished through those, the risks for many of the remaining anti-seizure medications are uncertain. So we're going to turn at this point from the didactic presentations to allow the members of the audience to ask questions, and we'll have a discussion. Thank you very much.
Okay, so we have several questions from the audience, and I'm going to gather them in separate groups. So do you think the low dose of valproic acid has the same efficacy of medium dose above 650 milligrams per day?
I think there is a linear response to dose for most anticonvulsant drugs, not all, but most. And it depends on the woman. If you do a big study and you take all comers, people that are easy to control, hard to control, you'll recall that multiple studies have shown you take a new onset epilepsy, you give them almost any drug that works in their class of epilepsy, you get about, right off the bat, about 50% will respond. So you may not be able to see differences in control across a group like that. But clearly there are some people that need to have higher dosages to be controlled. One dictum for some people in their approach is to start slow and try to stay low in their dosing to find a dose that would be controlled and only go up if they're having trouble with control at that point. So you're going to find some women, yes, they can be controlled with a low dose, and that's good. But there'll be others where you have to go to higher dosages, whether it's Valproate or some other drug.
Okay. Do you think there's a place for extended release presentations of valproic acid? We were taught that variations of concentrations during the day can harm more than stable concentrations.
There is some animal data to suggest this is an issue, that it's not very well defined out. We worry about total peak exposure versus total exposure. But there have been some physicians and statement papers saying we should try to use the extended release or to break up dosaging during the day. But the scientific proof for that is not complete at this point. It's very tenuous, I think.
And Dr. Mostacci, I think you were going to say something about it.
No, I completely agree. Okay, you use extended release formulation if you don't know what to do and you're forced to do that. But however, you can't rely on this kind of data to say that they are less dangerous. It's not a solution, however.
Okay, but would you prefer to use extended release presentation rather the standard one, for example?
Okay,
if you happen to.
In my practice, I use extended release formulation for almost every patient that uses Valproate, even males, because I prefer the extended release. This is the use in my center, and I do like that many times. Yeah, I would choose this this formulation. However, this is not a solution to the problem.
Okay, we have a question regarding status epilepticus breakthrough during pregnancy in the patient who has juvenile myoclonic epilepsy, and then you have changed the medication and you have tried first line of benzodiazepines, and then you start treating with levetiracetam, and then you fail. Would you use valproic acid in that particular setting of status epilepticus while pregnant?
As far as I know, there are no control studies in status epilepticus, and that's normal because you know that in refractory status epilepticus, we use only off-label medication, even in persons who are not pregnant. However, as a general rule, I think that you should do everything in a woman with a status epilepticus. Even I think you're meaning a convulsive status or a myoclonic status. A convulsive status. I think you should do everything. And maybe I wouldn't use Valproate as a first choice, but I would do the same things that I would do with a woman who's not pregnant. And then in those occasions, you have to see what you have to do, even with the delivery or other. However, you shouldn't be afraid of the medication in that occasion, I think. Even because we do not know the effects of a single large dose of medication in that occasion. It's different than being exposed to a medication every day, I think.
Okay, Dr. Meador, there's a question regarding what to do in young females who have just their first period, because even though there is a risk of being pregnant, we are not giving them probably the best treatment option in those very young female patients. What's your opinion about that in generalized genetic epilepsy, obviously?
I'm not quite sure what age they're talking about. And children would be a bit different than you're talking about adolescents. Most adolescents are in childbearing potential because they go through menarche pretty early. I've heard people talk about you're not giving them the best I had a discussion with someone about my first paper, and they said, well, when we came out with the New England Journal paper and showing these very big effects on IQ for Valproate, they said, well, you're denying women the best drug for their care. I'm not denying any focal epilepsy woman the best drug for their care, because that's not the best drug in focal epilepsy. Many others just absolutely equal. It is a better drug for some women with generalized epilepsy for generalized epilepsy overall. But if you give that to the woman without telling her about the risks, you're denying her informed consent, which I think is just as serious. And I have to say that in my practice, there's a very small number of women of childbearing potential Valproate, and I'm able to control the very large majority of these women with other agents.
And what about women with intellectual disability? Because we have seen a satanization of Valproate acid in the past 10 years, and probably nobody's using it. Would you say this is safe to use, having into account that probably they won't have children?
Well, I think I use it more there than I would in a woman of normal intellectual ability. Women with mental retardation, if it's very mild, could get pregnant. I have some that are married and have children. If you're talking about severe mental retardation, we would hope they're not getting pregnant, and there should be protection to prevent that in that situation. So the Valproate would be what would be used there. I think there's a couple of places where Valproate's very useful. Some of those are like people with primary generalized epilepsy, particularly certain ones, particular subsets. It's not just one thing though. It's like we talk about myoclonic epilepsy sometimes like it's one thing. It's not. It's a syndrome, and we have at least 9-10 genes for it, and that doesn't even begin to explain most of the juvenile myoclonic epilepsy. So there's probably a subgroup of them, a subgroup of the juvenile absence epilepsy, and a subgroup that we just have nondescriptly called generalized epilepsy because we see the EEG pattern that don't fit those syndromes, for which Valproate works. Unfortunately, we don't have a way to pick out which ones that work. The other thing, and those are genetic factors probably, the other thing is that we have no good information about hardly at all, is about the genetic risk. If we had ways to screen for the genetic risks, that would be very helpful. The drugs clearly, teratogens clearly work on a susceptible genetic substrate, and we see women that get exposed and their children are fine, others exposed and the kids do horrible. There is a study from Australia that showed that if a woman has a malformation on Valproate, the risk is very high. If she has another child, she's on Valproate, this same thing's going to happen. They're going to get a major malformation. So that's the one place we do have some indication about their personal prior pregnancy history does give indication what the malformation risk is going to be going in the future. But in general, we don't have those genetic factors to determine. And I think if you got women that are not getting pregnant because of severe mental retardation, because of they're a nun, because they're homosexual, then you don't have to worry about an unexpected pregnancy. But you can't just assume that you'll just wait till someone getting ready to get pregnant, because half the pregnancies, even in married women, are not planned. They're not unwanted, but they're not planned. And we have to plan ahead with the woman about her possible future pregnancies, and let her know about these risks. And I think the time to try different drugs to see if they're going to work separate from Valproate is well before the pregnancy, not after you get into the pregnancy. It's a mess then.
Definitely. And this is a question for Dr. Mostacci. What should we do when other therapies have failed? I mean, there is quite few papers regarding refractory genetic generalized epilepsies, but they do happen and they occur. And probably when you see a girl with childbearing potential, you start with other types of medications other than valproic acid. But what to do when those therapies have failed?
Yeah, I think this is the main situation in which you have to go back to Valproate. So you have to try other medications, and I cannot say how many you should try and what should happen to decide to go back to valproate. This is a question which has no response yet. It depends, I think, from the seizures, again, from the kind of seizures. If you have a woman with several tonic-clonic seizures, maybe you should recur to valproate earlier. If it's resistant, the epilepsy is resistant for other kind of seizure, I think it's different. However, you could try a polytherapy before going back to valproate. I think, for example, the B therapy, levetiracetam and lamotrigine, should be used before recurring to valproate. Yeah, you should do some attempts before going back to valproate, but you don't have any alternatives. That's what we are saying, and I think that we are agreeing on that. You should recur to valproate. You should try valproate, yeah, at low doses possibly.
Yeah, of course. So there's a question regarding the role of folinic acid during pregnancy, because we don't know actually the dose of it, if it should be 5 milligrams per kilo per day, or you should use intermediate dose. And it seems to be related to the outcome in terms of IQ and then neurodevelopmentally. So what would you recommend in terms of dose or of folic acid?
Yeah, concerning the dose, there isn't an univocal indication, because regarding structural teratogenicity, unfortunately, folic acid has not proved efficacy in defending from malformation due to or associated to antiepileptic medications. It was suggested that you should use high doses because you generally use high doses in women who have a high chance to have a child with spina bifida, which means another son or daughter who has spina bifida. This woman should take 5 milligrams per day, or however more than 4 milligrams per day of folic acid, while generally, as you know, the normal dose prescribed of folic acid is 400 micrograms, which means 12 times less than 5 milligrams. And so it was suggested that as women that take antiepileptic medication may have a son with spina bifida, and this is true for valproate, this is true for carbamazepine, with a higher chance than a woman that doesn't take the medication. This woman should be treated like the woman that has a child with spina bifida. And so some authors suggest 5 milligrams per day. Personally, I give 5 milligrams per day because there is not known harm. Yeah, there were some studies that said that if you take folic acid at high doses throughout pregnancy, meaning the second and the third trimester, there could be some problems. But generally speaking, it's not a problem to do a high dose of folic acid. So I prefer high doses. And then regarding cognitive interference, I will let Professor Meador answer, because maybe folic acid is more important to prevent interference with cognitive development than malformation associated with anti-seizure medication, while folic acid is very important to prevent malformation in general. So every woman should take it.
Yes, I agree. In general, I use a lower dose. I don't think we know the exact dose. It's 0.400 micrograms or 0.4 milligrams. It's kind of the general population dose here in the US. I usually go with women about a milligram. Sometimes they'll say take that with multivitamin. Multivitamin will have 0.4 or 0.8. So they end up on 1 or 1.4 to 1.8 in most of my population, unless they have a prior history of personal or family neurotube defect, whether it be at 4 to 5 milligrams. There are some concerns from general population data that dosages over 5 may cause behavioral problems, and that's not been worked out very well in women with epilepsy. We're not sure about that. And so, but I feel like dosages between 1 and 5, they're probably fine in women with epilepsy. The effect of the folate is, as Barbara mentioned, is not on malformations. There's actually been multiple reports of pregnancies on high-dose Valproate, high-dose folate in women on Valproate, and they still had birth defects. Now, it's not been a formal study, and there probably won't ever be prospective study to really determine if it's reducing a little bit, but clearly it's not totally effective. And in the other anticonvulsant drugs, we're not seeing effects on malformations either. So, but we have seen reports from our study in the US and from Norway, I think it's Norway, somewhere in Scandinavia, sorry for my Scandinavian friends, but I'm pretty sure it's Norway, that have showed effects of periconceptual folate on cognitive outcomes or behavior outcomes, improving IQ, reducing language delay, reducing autistic-like behaviors. And in particular, the Norwegian study delineate the time window of this, and it's really the first multiple weeks of the pregnancy, like about the first 8 weeks of the pregnancy. If you miss that window, then women will get folate because they see the OB by that time. They're getting folate anyway, very high dosages for growth, cell growth in the child, but it doesn't have that effect on cognition. That's why I emphasize that women should just start it, keep taking it, because of the high incidence of unplanned pregnancies. And by the time they figure out they're pregnant, they've already missed a big part of that window at best.
Okay, we have another question. It is regarding that patient that is on Valproate that wouldn't change. What would you advise to do that to that patient? Because this is something that happens quite often, and the Italian group has made some articles regarding the failure of other treatment other than valproic acid in genetic generalized epilepsies. So what would you advise to a woman who is reluctant to discontinue valproic acid and is willing to have an offspring?
Is that to me or Barbara?
Both of you.
Okay.
Maybe we will. You start.
Okay.
It is a difficult question.
I would advise them of the risks. I would advise them not to get pregnant. I would advise them to use a consistent contraception, and the best reversible, in case they do want to have pregnancy in the future, best reversible contraception, I think, are IUDs. They're much safer than they were many years ago. I have a lot of women that use hormonal IUDs. You don't have to remember to take the pill. If you forget to take the pill, boom, you got a breakthrough pregnancy. So I usually recommend something like, and there are problems with some of the medicines interacting with lowering effectiveness of birth control pills, like enzyme-inducing drugs, or the birth control pills lower the level of a drug like lamotrigine, which doesn't affect the birth control pills, but is affected by them. So I find it much easier to use IUDs, recommend IUDs for contraception. It should be the woman's choice. Now, if she's not having intercourse, or then if she's not planning on getting pregnant, that might be a very reasonable choice. If she's not using contraception and she's having intercourse, I don't think it's a very wise choice, but should still be the woman's choice and not mine to make.
I agree. I would add only that I agree also that it happens it happens often to have this kind of discussion with women, and I think that you should accept the woman's will, as I told even in the presentation. But each time you see that woman, I think you should again do this discussion. Again, you should inform her and ask her whether she has changed her mind, and not to insist, but to be sure that she is really fully informed, and that she has the chance to discuss it with her doctor every time, many times. Maybe the first time It happens with many people with epilepsy, not only with women that take Valproate. It happens sometimes with the people to whom you would withdraw one medication because they're taking two medications since a long time, and you think that they do not need any more of those two medications, and they do not want to abandon one medication because they are afraid to have another seizure. I think you should not insist, but that you should kindly remind that person every time that your opinion is different and that maybe another way is possible and wiser.
Yeah, definitely. We have a last question regarding, do you think that the major congenital malformations are related to the mechanism of action? Because you see a higher risk with phenobarbital and valproic acid, and they share a GABA mechanism of action. Do you think that that's related to the sole mechanism of action, or it's related to another type of
I think that it's probably related to the tropism, to different tissues of the medication. For example, levetiracetam has a very low teratogenic potential. Maybe it doesn't have any teratogenic potential, and it's a drug that is a special tropism only for the nervous system. So the heart is not does not have any receptor for levetiracetam, for example. So I think that the problem is different. For example, Valproate maybe has a strong tropism for the nervous system because we have spina bifida and we have IQ problems. I think it's more related to other kinds of mechanisms than the one that works in their epileptogenic mechanism.
I would say that I agree, and I would say that anesthesia medications as a class are all teratogens, and that they act in a dose-dependent manner, and that dose-dependent manner for some doesn't require much dose, but others may require huge dosages to get there. It's hard to translate the animal data to humans because a lot of it's not even published, even though the regulatory agents require this. However, if you look at one of the models for cognitive impairment, one that came out of the fetal alcohol syndrome, the apoptotic neuronal apoptosis in the immature brain, it's interesting to see that a drug like Valproate and benzos and phenobarb and phenytoin, which is not a GABA agent, can produce this same neuronal apoptosis. But the difference, you might ask, well, then why does Valproate have more teratogenicity, or why does it have more cognitive effects in this model with it? By the way, there's a dying off of cells, but it's not the dying of cells that cause the cognitive problem primarily. It's the remaining nerve cells, the synaptogenesis doesn't work correctly. But why is this disparity? If phenytoin is positive in this model, why is Valproate so much greater a risk for malformation? And it's because for phenytoin, the effect kicks in at a dose equal to kind of the upper end of the therapeutic range for phenytoin. And for Valproate, it kicks in below the therapeutic range, just below the therapeutic range. So almost any dose you're using for epilepsy is going to give you risk of that apoptosis occurring along with the bad synaptogenesis and the related cognitive and behavioral abnormalities that can occur.
Okay, and I promise that this is the last question, is whether on juvenile myoclonic epilepsy, which is on valproic acid, would you perform an EEG before the pregnancy is sick, and therefore you changed your medication because of the result of the EEG? It's a tricky question, I know.
The EEG helps when you're making a medication. Let's say you take somebody off medication, or in this case, thinking about switching them before pregnancy. I hope you would do this before pregnancy. Thinking about switching them off Valproate. If it's a very epilepsy, we see sometimes people covering the EEGs, the primary general epilepsy, they have discharges all the time. And but yet they're not having clinical seizures, so they're adequately controlled from a clinical standpoint. I'd worry a little bit more about that patient than someone whose EEG is clean, but neither one of them give you 100% certainty in whether they're going to be controlled by another drug or not. I mean, if you had another drug and discharges went down, you'd feel better about taking off Valproate or whatever drug it was that you're adding something to, I would think, that maybe have more safety, but you don't know for sure.
In our experience, in generalized epilepsies, EEG is important when you are withdrawing. When you are withdrawing, when you are switching therapy, if the EEG worsens, then you have to be a bit careful. But yeah, I wouldn't take the EEG as the rule to decide whether to stop or to change medication. The EEG in generalized epilepsy, I agree, may be really disturbed all the time, even in people who are in which epilepsy has resolved.
Okay, so yeah, again, thank you very much for this presentation and the discussion. It has been very enlightening, and thank you for your time also accepting this invitation. Thank you very much.
Thank you. Have a great day.
Okay. Bye-bye.